Lewis's Medical Surgical Nursing, 11th edition, Chapter 19, Postoperative Care. The postoperative period begins immediately after surgery and continues until the patient is discharged from medical care. This chapter focuses on the multiple concepts central to postoperative nursing. Nursing plays a vital role in supporting ventilation and perfusion, maintaining fluid and electrolyte balance, promoting comfort, reducing infection, and promoting safety. Specific surgical procedures and related postoperative care are discussed in the appropriate chapters of this text. Postoperative care of surgical patient. The patient's immediate recovery period is managed in a post-anesthesia care unit, PACU. It is usually next to the operating room, OR. This location limits transportation of the patient right after surgery and gives ready access to anesthesia and OR staff. The goals of PACU care are to maintain patient safety during recovery from anesthesia and identify actual and potential patient problems that may occur because of anesthesia and surgery and intervene appropriately. Post-anesthesia care unit admission. The patient's admission to the PACU is a joint effort among the anesthesia care provider, ACP, OR nurse, and PACU nurse. This collaboration fosters a smooth transfer of care to the PACU and helps determine which phase we assign the patient. PACU progression. There are 3 phases of post-anesthesia care. During each phase, we provide different levels of care depending on the patient's needs. How patients move through the phases of care is determined by their condition and the type of anesthesia they received. If a patient assigned to phase 1 care on admission to the PACU is stable and recovering well, the patient may rapidly progress through phase 1 to either phase 2 care or an inpatient unit. This accelerated progress is called rapid post-anesthesia care unit progression, RPP. Another accelerated system of care is fast tracking, which involves admitting ambulatory surgery patients directly to phase 2 care. Although RPP and fast tracking can result in time and cost savings, patient safety is the primary factor determining where and at what level we provide postoperative care. Phase 1, Initial Assessment. On admission of the patient to the PACU, the ACP gives you a post-anesthesia handoff report. Handoff reports should be standardized and interactive, allowing you to ask questions and clarify information. The ACP should stay in the PACU until you accept responsibility for the care of the patient. Potential problems in the postoperative period are shown in Figure 19.1. Table 19.3 describes key parts of a PACU assessment. Begin your initial assessment by evaluating the patient's airway, breathing, and circulation, ABC status. Residual neuromuscular blockade, opioid use, and patient characteristics such as sleep-disordered breathing, e.g. obstructive sleep apnea, OSA, abnormal airway anatomy, affect oxygenation and ventilation. Be alert for signs of inadequate oxygenation and ventilation. Any sign of respiratory distress needs prompt intervention. Pulse oximetry monitoring is a non-invasive means of assessing oxygenation and can provide an early warning of hypoxemia. Transcutaneous carbon dioxide, PTCCO2, and end-tidal CO2, PET-CO2, capnography monitoring are used to detect respiratory depression in high-risk patients. Volumetric capnography and acoustic respiratory rate monitoring can help you detect respiratory distress early. Pulse oximetry, capnography, PTCCO2, and PET-CO2 are discussed in Chapter 25. Note and assess changes in ECG findings from the preoperative baseline. Measure the BP and compare it with baseline readings. Invasive monitoring, e.g. arterial BP, may be needed. Assess body temperature, peripheral pulses, capillary refill, and skin condition, e.g. color, moisture. Any signs of inadequate tissue perfusion need prompt intervention. Focus the initial neurologic assessment on level of consciousness, orientation, sensory and motor status, and size, equality, and reactivity of the pupils. The patient may be awake, drowsy but arousable, or asleep. Because hearing is the first sense to return in the unconscious patient, explain all activities to the patient from the time of admission to the PACU. If the patient received a regional anesthetic, e.g. spinal, epidural, Sensory and motor blockade may still be present, and you should assess dermatome levels. During recovery from regional anesthesia, sensory and motor function first returns distal to the site where the anesthetic was given. This means the areas near the site of injections are the last to recover. Assess the urinary system by measuring intake and output and determining fluid balance. Intraoperative fluid totals are part of the ACP report. Note the presence of all IV lines, all irrigation solutions and infusions, and all output devices, including catheters and wound drains. Assess the surgical site. Note the condition of any dressings and the type and amount of any drainage. Implement orders related to incision care. The rest of this chapter discusses the nursing management of select problems. You can apply this information to patients in both the PACU and clinical unit. Respiratory problems. Etiology, PACU. In the immediate post-anesthesia period, most common causes of airway compromise include obstruction, hypoxemia, and hypoventilation. Patients at high risk include those who 1. Have had general anesthesia, 2. Are older than 55 years of age, 3. Have a history of tobacco use, 4. Have pre-existing lung disease and or sleep-disordered breathing, 5. Are obese, 6. Have comorbidities, e.g. renal disease, diabetes, hypertension, or 7. Have undergone airway, thoracic, or abdominal surgery. Pulmonary complications pose the greatest risk to patients in the post-anesthesia period and in the immediate postoperative period. High-risk patients should be monitored in a critical care or post-anesthesia care unit. Airway obstruction is often caused by the patient's tongue blocking the airway. The base of the tongue falls backward against the soft palate and includes the pharynx. It is most pronounced in the supine position in the patient who is extremely sleepy after surgery. Hypoxemia, a partial pressure of arterial oxygen, PaO2, less than 60 milligrams of mercury, is characterized by a variety of nonspecific clinical signs and symptoms, ranging from agitation to somnolence, hypertension to hypotension, and tachycardia to bradycardia. Pulse oximetry will show low O2 saturation, less than 92%. The most common cause of hypoxemia after surgery is atelectasis. Atelectasis, alveolar collapse, may be the result of bronchial obstruction caused by retained secretions, decreased respiratory excursion, or general anesthesia. Atelectasis occurs when mucus blocks bronchioles or there is not enough alveolar surfactant, substance that holds the alveoli open. As air becomes trapped beyond the plug and is absorbed, the alveoli collapse. Atelectasis may affect a part of or an entire lobe of the lung. Other causes of hypoxemia include pulmonary edema, pulmonary embolism, PE, aspiration, and bronchospasm. An accumulation of fluid in the alveoli can cause pulmonary edema. It may be the result of fluid overload, heart failure, prolonged airway obstruction, sepsis, or aspiration. After surgery, patients are at risk for aspiration of gastric contents into the lungs. This can occur because anesthesia depresses the respiratory protective airway reflexes. Gastric aspiration is a potentially serious emergency. It may result in laryngospasm, pneumonia, and pulmonary edema. Because of the grave consequences of aspiration of gastric fluids, prevention is the goal. Bronchospasm is the result of an increase in bronchial smooth muscle tone with the resulting closure of small airways. Airway edema develops, causing secretions to build up in the airway. The patient will have wheezing, dyspnea, use of accessory muscles, hypoxemia, and tachypnea. Bronchospasm may be due to aspiration, endotracheal intubation, pharyngeal suctioning, or an allergic response. Bronchospasm may occur in any patient. It occurs most often in patients with a history of smoking, asthma, and chronic obstructive pulmonary disease. Hypoventilation, a common complication in the PACU, is characterized by a decreased respiratory rate or effort, hypoxemia, and increasing hypercapnia, increased PaCO2. It may result from depression of the central respiratory drive, from anesthesia, or use of opioids, poor respiratory muscle tone from neuromuscular blockade or disease, or a combination of both. Clinical unit. Common causes of respiratory problems are atelectasis and pneumonia, especially in patients with comorbidities, e.g., OSA, COPD, heart failure, and after abdominal and thoracic surgery. The development of mucus plugs and decreased surfactant production is directly related to hypoventilation, immobility and bed rest, ineffective coughing, and history of tobacco use. Increased bronchial secretions occur when the respiratory passages have been irritated by heavy smoking, COPD, pulmonary infection, or dry mucous membranes that occur with intubation, inhalation anesthesia, and dehydration. Without intervention, atelectasis can progress to pneumonia. Nursing management, respiratory problems. Nursing assessment. Respiratory assessment requires evaluation of airway patency, chest symmetry, and depth, rate, and character of respirations. Impaired ventilation may first be seen as slowed breathing or reduced chest and abdominal movement during breathing. Abdominal or accessory muscle use may occur with respiratory distress. Auscultating breath sounds will alert you to decreased or absent breath sounds. These findings may mean airflow is diminished or obstructed. Arouse patients with poor respiratory effort, noisy respirations, or other signs of respiratory distress at once, and have them take deep breaths. Regular monitoring of vital signs, including pulse oximetry, capnography, or other technology-supported monitoring, e.g. acoustic monitoring, and a thorough respiratory assessment allows you to recognize early signs of respiratory problems. Manifestations of hypoxemia include tachypnea, gasping, anxiety, restlessness, confusion, and a rapid or thready pulse. Note and record the characteristics of sputum or mucus. Mucus from the trachea and throat is normally colorless and thin in consistency. Sputum from the lungs and bronchi is normally thick with a pale yellow tinge. Changes in sputum, e.g. color, may indicate a respiratory infection. Nursing diagnosis. Nursing diagnosis and collaborative problems related to respiratory problems include impaired airway clearance, impaired breathing, impaired gas exchange, risks for aspiration, potential complications, pneumonia, atelectasis. Nursing implementation. In the PACU, nursing interventions are aimed at preventing and treating respiratory problems. Proper positioning of the patient aids breathing and protects the airway. Once conscious, place the patient in a supine position with the head of the bed elevated. This position maximizes expansion of the thorax by decreasing the pressure of the abdominal contents on the diaphragm. Start O2 therapy via nasal cannula or face mask if ordered. O2 helps to eliminate anesthetic gases and meet the increased demand for O2, resulting from decreased blood volume or increased metabolism. All postoperative patients are at risk for atelectasis. Encourage deep breathing to aid gas exchange and promote the return to consciousness. Once the patient is more awake, deep breathing, coughing, and use of an incentive spirometer help prevent alveolar collapse and move respiratory secretions to larger airway passages for expectoration. One technique known as sustained maximal inspiration requires the patient to inhale as deeply as possible and at the peak of inspiration, hold the breath for a few seconds, then exhale. This is followed by another deep breath and cough. The use of an incentive spirometer helps by giving visual feedback of respiratory effort. Diaphragmatic or abdominal breathing involves inhaling slowly and deeply through the nose, holding the breath for a few seconds, and then exhaling slowly and completely through the mouth. Place the patient's hand lightly over the lower ribs and upper abdomen so that the patient can feel the abdomen rise during inspiration and fall during expiration. Unless contraindicated, have the patient perform these maneuvers 10 times every hour while awake. Effective coughing is essential in mobilizing secretions. Secretions are in the respiratory tract. Deep breathing often moves them up and stimulates the cough reflex. Splinting an abdominal incision with a pillow or a rolled blanket supports the incision and aids in coughing and expectorating secretions. Change the patient's position every 1 to 2 hours to allow full chest expansion and increase perfusion in both lungs. Help the patient sit in a chair and ambulate as soon as ordered. Provide adequate and regular pain medication. Incisional pain often is the greatest barrier to patient participation in effective breathing exercises and ambulation. Reassure the patient that these activities will not cause the incision to open. Adequate hydration, either parenteral or oral, is essential to maintain the integrity of mucous membranes and to keep secretions thin and loose for easy expectoration. Other nursing interventions for specific respiratory problems are detailed in Table 19.5. A nursing care plan for the post-operative patient is available on the website for this chapter. Cardiovascular problems. Etiology. PACU. In the immediate post-anesthesia period, the most common cardiovascular problems include hypotension, hypertension, and dysrhythmias. Patients at greatest risk for altered cardiovascular function include those with altered respiratory function, those with a history of cardiovascular disease, older adults, the debilitated, and the critically ill. Hypotension can cause hypoperfusion to the vital organs, especially the brain, heart, and kidneys. Clinical signs of disorientation, loss of consciousness, chest pain, and oliguria reflect hypoperfusion, hypoxemia, and the loss of physiologic compensation. Intervention must be prompt to prevent the devastating complications of cardiac ischemia or infarction, cerebral ischemia, renal ischemia, and bowel infarction. The most common cause of hypotension in the PACU is fluid and blood loss, which may lead to hypovolemic shock. Hemorrhage is always a risk of surgery. Marked blood loss is possible when cauterization or sutures fail. Hemorrhage most often occurs internally. Assess for changes in level of consciousness and vital signs. If detected, treatment is aimed toward restoring circulating volume. If there is no response to fluid administration, heart dysfunction may be the cause of hypotension. Primary heart dysfunction, which may occur in myocardial infarction, cardiac tamponade, or PE, results in an acute drop in cardiac output. Secondary heart dysfunction occurs because of the negative chronotropic rate of heart contraction and negative ionotropic force of heart contraction effects of drugs such as beta-adrenergic blockers, digoxin, or opioids. Other causes of hypotension include decreased systemic vascular resistance and dysrhythmias. Hypertension most often occurs from sympathetic nervous system stimulation. This may be the result of pain, anxiety, bladder distension, or respiratory distress. Hypertension may be related to hypothermia and pre-existing hypertension. Many problems can cause dysrhythmias. These include hypoxemia, hypercapnia, electrolyte and acid-base imbalances, circulatory instability, pre-existing heart disease, hypothermia, pain, surgical stress, and many anesthetic agents. Clinical unit. On the clinical unit, postoperative fluid and electrolyte imbalance are contributing factors to heart problems. Such imbalances may result from a combination of the body's normal response to the stress of surgery, excessive fluid losses, and IV fluid replacement. The body's fluid status directly affects cardiac output. Fluid retention during postoperative days 1 to 3 can result from the stress response, which maintains both blood volume and BP. Fluid retention results from the release of antidiuretic hormone, ADH, and adrenocorticotropic hormone, ACTH, and activation of the renin-angiotensin-aldosterone system, ROS. ADH release leads to increased water reabsorption and decreased urine output, increasing blood volume. ACTH stimulates the adrenal cortex to secrete cortisol and, to a lesser degree, aldosterone. Fluid losses resulting from surgery decrease kidney perfusion, stimulating the ROS and causing marked release of aldosterone. Both mechanisms that increase aldosterone lead to significant sodium and fluid retention, thus increasing blood volume. Fluid overload may occur during this period of fluid retention if we infuse IV fluids too rapidly, when chronic disease, e.g. heart, kidney, exists, or when the patient is an older adult. Fluid deficits from untreated preoperative dehydration, blood loss during surgery, or slow or inadequate fluid replacement can decrease cardiac output and tissue perfusion. Losses from vomiting, bleeding, wound drainage, or suctioning can contribute to fluid deficits. Hypokalemia can result from urinary and gastrointestinal (GI) tract losses. Low serum potassium levels directly affect the heart's contractility and may contribute to decreases in cardiac output and tissue perfusion. The patient can receive potassium replacement, usually 40 milliequivalents per day, if renal function is adequate. A urine output of at least 0.5 milliliters per kilogram per hour and a normal serum creatinine are considered indicative of adequate renal function. The state of tissue perfusion or blood flow affects cardiovascular status. The stress response contributes to an increase in clotting tendencies by increasing platelet production. A venous thromboembolism, VTE, may form in leg veins because of venous stasis, vein injury, or a hypercoagulable state. VTE is especially common in older adults, obese persons, immobilized patients, and patients with a history of PE or predisposition to clotting. It is a potentially life-threatening complication because it may lead to PE and infarction. Suspect PE in any patient with tachypnea, chest pain, hypotension, agitation, tachycardia, and dyspnea, especially when the patient is already receiving O2 therapy. Superficial thrombophlebitis is an uncomfortable but less serious complication. It may develop in a leg vein because of venous stasis, or in the arm veins because of irritation from IV catheters or solutions. PE and VTE are discussed in chapters 27 and 37 respectively. Syncope, fainting, may result from decreased cardiac output, fluid deficits, or deficits in cerebral perfusion. Syncope often occurs because of postural hypotension when the patient ambulates. It is more common in the older adult or in the patient who has been immobile for long periods. Normally, when the patient stands up quickly, the arterial baroreceptors respond to the accompanying fall in BP with sympathetic nervous system stimulation. This produces vasoconstriction and maintains BP. These sympathetic and vasomotor functions may be diminished in the older adult, immobile, or post-anesthesia patient. Nursing management, cardiovascular problems. Nursing assessment. The most important aspect of the cardiovascular assessment is frequent vital sign monitoring. Plan to obtain vital signs every 15 minutes in phase 1, or more often until stabilized, and then less often in phase 2. Compare postoperative vital signs with preoperative and intraoperative findings to determine when the signs are returning to baseline. Notify the ACP or HCP if any of the following occurs. Systolic blood pressure less than 90 or greater than 160. Pulse rate less than 60 or greater than 120. Pulse pressure narrows. BP trends gradually decrease or increase over several consecutive readings. Change in heart rhythm. Hypotension, accompanied by a normal pulse and warm, dry, pink skin, is usually from the residual vasodilating effects of anesthesia and suggests only a need for continued observation. Hypotension, accompanied by a rapid or weak pulse and cold, clammy, pale skin, may indicate impending hypovolemic shock and needs immediate treatment. ECG monitoring is recommended for patients who have a history of heart disease and for all older patients who have undergone major surgery, regardless of whether they have heart problems. Assess the apical radial pulse carefully and report any deficits or irregularities. Assess peripheral pulses in skin color, temperature, and moisture for valuable information about tissue perfusion. Nursing diagnoses. Nursing diagnoses and collaborative problems related to cardiovascular problems include altered blood pressure, impaired cardiac output, risk for bleeding, potential complications, hypovolemic shock, VTE. Nursing implementation. PACU. Begin treatment of hypotension with O2 therapy to promote oxygenation of hypoperfused organs. Because the most common cause of hypotension is fluid loss, Give IV fluid boluses to normalize BP. Inspect the surgical incision to determine if excess bleeding is the cause of volume loss. Primary heart dysfunction may require drug intervention. Peripheral vasodilation and hypotension may require vasoconstrictive drugs to increase systemic vascular resistance. Treatment of hypertension centers on removing the cause of sympathetic nervous system stimulation. This may include giving analgesics, assisting with voiding, and correcting respiratory problems. Remorphing corrects hypothermia-induced hypertension. A patient with pre-existing hypertension or who has undergone heart or vascular surgery usually needs drug therapy to reduce BP. Since most dysrhythmias seen in the PACU have identifiable causes, treatment is directed toward removing the cause. Correcting the cause usually corrects the dysrhythmias. With life-threatening dysrhythmias, e.g. ventricular tachycardia, follow your agency's protocol for advanced cardiac life support. Clinical unit. Continue to monitor vital signs. Keep an accurate intake and output record, monitor laboratory findings, e.g. electrolytes, hematocrit, and manage IV therapy after surgery. Early ambulation is the most significant general nursing measure to prevent complications. The exercise associated with walking, 1. Increases muscle tone, 2. Stimulates circulation, which prevents venous stasis and VTE, and speeds wound healing, and 3. Increases vital capacity and supports normal respiratory function. Begin progression to ambulation by first raising the head of the patient's bed for 1 to 2 minutes. Then help the patient to sit, with legs dangling, while monitoring the pulse rate. If you do not note changes or problems, start ambulation with ongoing monitoring of the pulse. If you note changes in the pulse or dizziness occurs, sit the patient in a nearby chair. The patient should stay in this location until the BP and pulse are stable. Then help the patient back to bed. If dizziness occurs, it is often frightening to the patient. Injury can result from a fall, so take measures to ensure patient and staff safety. Neurologic and psychologic problems. Etiology. PACU. Postoperatively, emergence delirium is a short-term neurologic change manifested by behaviors such as restlessness, agitation, disorientation, thrashing, and shouting. If delirium occurs, first suspect hypoxia. Other causes include anesthetic agents, bladder distension, pain, long duration of preoperative fasting, residual neuromuscular blockade, or the presence of an endotracheal tube. Delayed emergence can be a problem after surgery. Patients with delayed emergence spend longer periods in the PACU and have prolonged hospital courses. Identifying the causative factors is critical for determining appropriate interventions. The most common cause of delayed emergence after anesthesia is drug-related. This includes anesthetic agents as well as drugs used during the perioperative period. Contributory non-pharmacologic causes include metabolic disorders, electrolyte imbalances, hypertension, liver disease, uremia, central anticholinergic syndrome, and hypothyroidism. Other causes can include hypoxia, hypercapnia, hemorrhage, and embolism. Clinical unit. Two types of cognitive impairment seen in surgical patients are postoperative cognitive dysfunction, POCD, and delirium. POCD is a decline in the patient's cognitive function, e.g., memory, ability to concentrate, for weeks or months after surgery. POCD occurs primarily in the older surgical patient. Pre-existing cognitive impairment, duration of anesthesia, complications during surgery, and infection contribute to the development of POCD. Quickly and thoroughly investigate any changes in mental status, as the causes may be life-threatening. Postoperative delirium is more common in the older patient, but can occur in patients of any age. Delirium may be the result of severe pain, fluid and electrolyte imbalances, hypoxemia, drug effects, sleep deprivation, and sensory deprivation or overload. Signs include cognitive dysfunction, varying levels of consciousness, altered psychomotor activity, and a disturbed sleep-wake cycle. See Chapter 59 for more about delirium. Anxiety and depression may occur and correlate with an increased likelihood for complications. These responses may be part of grieving for lost body parts or altered body function, or for loss of independence during recovery and rehabilitation. Alcohol withdrawal delirium results from the patient undergoing alcohol withdrawal. It is characterized by restlessness, insomnia, nightmares, irritability, and auditory or visual hallucinations. Chapter 10 discusses the identification and management of alcohol withdrawal delirium. Nursing management, neurologic and psychologic problems, nursing assessment. Assess the patient's level of consciousness, orientation, memory, and ability to follow commands. Determine the size, reactivity, and equality of the pupils. Assess the patient's sleep-wake cycle and sensory and motor status. Determine the possible cause if the patient has an altered neurologic status. If the patient was mentally alert before surgery and becomes cognitively impaired after surgery, you need to do further assessment to rule out hypoxia, delirium, or POCD. Nursing diagnoses. Nursing diagnoses related to neurologic and psychologic problems include confusion, disturbed body image, sleep deprivation. Nursing implementation. PACU. The most common cause of agitation in the PACU is hypoxemia, so you need to focus attention on evaluating respiratory function. Once you have ruled out hypoxemia or other known causes of postoperative delirium, sedation may be beneficial in controlling agitation. Because the most common cause of delayed emergence is prolonged drug action, delays in awakening usually spontaneously resolve with time. If necessary, antagonists can reverse the effects of benzodiazepines and opioids. Interventions to prevent perioperative delirium, other than reducing the depth of anesthesia, have not significantly reduced the incidence of emergence delirium. Until the patient is awake and able to communicate effectively, you are responsible for patient safety. This includes monitoring physiologic status, having the side rails up and call bell available, securing equipment, e.g. IV lines, artificial airways, using 2 patient identifiers before giving drugs or completing treatments, and verifying allergies. Clinical unit. To prevent or manage postoperative delirium, or POCD, address any potential contributing factors. Maintain normal physiologic function by achieving fluid and electrolyte balance, adequate nutrition and sleep, pain management, proper bowel and bladder function, and early mobilization. To help orient the patient, use specific aids such as clocks, calendars, and photos. To prevent or limit psychologic problems, provide adequate support for the patient. This includes listening to and talking with the patient, offering explanations and reassurance, and encouraging the presence and aid of the patient's caregivers. Evaluate the patient's behavior to distinguish a normal reaction to a stressful situation from one that is becoming abnormal or excessive. Recognize alcohol withdrawal delirium can be a challenge. Record and report any unusual or disturbed behavior so that a diagnosis can be made and treatment started. Pain and discomfort. Etiology. Despite the availability of pain-relieving drugs and techniques, pain is a common problem and a significant fear for patients. Pain is caused by the interaction of several physiologic and psychologic factors. The incision and retraction during surgery traumatize the skin and underlying tissues. In addition, there may be reflex muscle spasms around the incision. Anxiety and fear, sometimes related to the anticipation of pain, create tension and further increase muscle tone and spasm. Positioning during surgery and the use of internal devices, such as an endotracheal tube or catheters, may also cause discomfort. The effort and movement associated with deep breathing, coughing, and ambulating may worsen pain by creating tension on the incision area. Other sources of discomfort include nausea and vomiting, environmental noises, noxious odors, and shivering. The patient does not feel pain when the internal viscera are cut. Pain does, however, come from pressure in the internal viscera. This means deep visceral pain may signal a complication such as intestinal distension, bleeding, or abscess formation. Pain increases the risk for atelectasis and impaired respiratory function. Nursing management, pain. Nursing assessment. Assess the patient on arrival to the PACU and in frequent intervals. The patient's self-report is the single most reliable indicator of pain. Use a pain scale, such as a numeric or FACES pain scale, to assess the severity or intensity of pain. Pain scales are discussed in Chapter 8. Assess pain levels at rest and during activities. Since verbalization of pain is not always possible in the PACU, assess the patient for other indications of pain, e.g. restlessness, grimacing, changes in vital signs. You need to identify the location of the pain. Expect that patients will have incisional pain, especially with movement, and with certain procedures, e.g. removal of drains. Other causes of pain, such as full bladder, may be present. Always involve patients in the assessment and management of their pain. Assessing patients from different cultures or who do not speak English may be challenging. Take extra time to explore the pain experience with these patients. Adapt care as needed to meet the patient's unique needs and expectations for pain control. Nursing implementation. Begin before surgery to develop a plan for pain control that includes behavioral modalities and control of anxiety. Evaluate any adjustments to or continuation of drugs used to treat any chronic pain during the preoperative phase. During this time, teach patients to report pain and how it will be managed after surgery. Share pain management plans during the handoff report. The acute pain of surgery almost always requires the use of analgesics. Organizational approaches can reduce pain intensity with fewer side effects associated with the analgesic use. These approaches include using procedure-specific pain management guidelines with titration of analgesia based on specific patient needs. Pain control techniques include the use of single modalities, e.g. opioid drugs, PCA, regional analgesic, local anesthetic infiltration, or multimodal analgesia. Multimodal analgesia, or the use of two or more analgesics with different mechanisms of action, e.g. an opioid and a non-steroidal anti-inflammatory drug, is recommended. Multimodal analgesia reduces pain, opioid use, and opioid-related adverse effects. It also enhances recovery and increases patient satisfaction. These drugs may be given via the same or different routes. Choice of modality should be procedure and patient specific. The HCP often writes orders for pain medication and other comfort measures on an as-needed PRN basis. Time giving analgesics to ensure that they are in effect during activities that may be painful, such as walking. Although opioid analgesics are often essential for the patient's comfort, they are undesirable side effects. The most common include constipation, nausea and vomiting, respiratory and cough depression, and hypotension. Before giving any analgesic, first assess the patient's pain, including location, quality, and intensity, vital signs, and level of consciousness. Treat incisional pain as ordered. If the patient reports chest or leg pain, analgesics may mask a complication, e.g. VTE. If it is gas pain, opioids can worsen it. If the analgesic either does not relieve the pain or makes the patient lethargic or somnolent, notify the HCP and request a change in the order. Patient-controlled analgesia, PCA, allows the self-administration of predetermined doses of analgesia by the patient. The goals of PCA are to provide immediate analgesia and maintain an acceptable level of pain control. Continuous infusions allow for a steady blood level of analgesia, with additional patient doses used prior to painful events, e.g. walking, deep breathing, and coughing, or for breakthrough pain. Opioid-tolerant patients may need patient-administered boluses. The route of delivery may be IV, oral, epidural, or transdermal. transdermal route is for short-term pain management and may offer advantages over the IV route, e.g., needleless, low infection risk, decreased drug errors associated with pump malfunction or inaccurate programming. Some advantages of PCA are early ambulation, better pain management than with as-needed analgesia, and greater patient satisfaction. Epidural analgesia is the infusion of opioid analgesics through a catheter placed into the epidural space surrounding the spinal cord. The goal of epidural analgesia is delivery of the drug directly to opioid receptors in the spinal cord. Administration methods include intermittent bolus dosing, continuous infusion, and epidural PCA. This technique results in a constant circulating level and a reduced total dose of medication. The use of epidural analgesia in managing pain after surgery is increasing. Perineural local anesthesia, the infiltration of a non-opioid drug into the surgical site, is another way to manage postoperative pain. A disposable or mechanical infusion pump delivers the local anesthetic via a catheter directly to the surgical incision site. A single dose of bupivacaine liposome injectable suspension, Exparel, provides pain relief with reduced opioid needs for up to 72 hours. Complementary and alternative therapies such as music therapy, guided imagery, relaxation exercise, and aromatherapy are effective adjuncts in pain management. Non-drug approaches such as repositioning, massage, and distraction can enhance pain management. Temperature changes. Etiology. Knowing the patient's temperature in the postoperative period is valuable. We're giving increased attention to the importance of maintaining a normal body temperature. Perioperative temperature management is a quality measure by the Surgical Care Improvement Project, SCIP, a national partnership of organizations whose goal it is to reduce surgical site infections, SSIs. Hypothermia. Perioperative hypothermia is a core body temperature less than 96.8 degrees Fahrenheit, 36 Celsius. Hypothermia occurs when heat loss exceeds heat production. Heat loss may occur due to skin exposure, use of cold irrigants, skin preparations, and unwarmed inhaled gases. Although all patients are at risk for postoperative hypothermia, patients with low preoperative core body temperatures, those with systolic BP less than 140, older patients, female patients, and patients who receive epidural or spinal anesthesia are at a higher risk. Long surgical procedures, open cavity procedures, e.g. abdominal or thoracic, and prolonged anesthetic administration lead to redistribution of body heat from the core to the periphery. This places the patient at an increased risk for hypothermia and complications. Complications associated with hypothermia can include vasoconstriction with resulting hypertension, compromised immune function, bleeding, untoward cardiac events, SSIs, altered drug metabolism, increased pain, and shivering. Shivering can increase resting energy expenditure and O2 consumption up to 500%, which can lead to hypoxemia and myocardial ischemia, angina. Shivering can also increase carbon dioxide production, increase heart rate, BP, and intracranial pressure, and significantly affect the patient's comfort level. Fever. Fever may occur at any time after surgery. SSI, particularly from aerobic organisms, is often accompanied by a fever that spikes in the afternoon or evening and returns to near normal levels in the morning. The respiratory tract may be infected from stasis of secretions in areas of atelectasis. Urinary tract infections, UTIs, may occur from catheterization. Superficial thrombophlebitis may occur at the IV site. VTE in the leg veins may raise temperature. Surgical patients who receive antibiotic therapy are at risk for Clostridium difficile infections. Manifestations of C. diff may include fever, diarrhea, and abdominal pain. Intermittent high fever accompanied by shaking chills and diaphoresis suggests septicemia. This may occur at any time after surgery. It can result from microorganisms being introduced into the bloodstream during surgery, especially in GI or GU procedures. Septicemia may occur later from a wound or UTI. Malignant hyperthermia, MH, is a muscle metabolism disorder that is triggered by general anesthetic agents. Although often a late sign, it is characterized by a rapid rise in body core temperature and severe muscle rigidity. Other signs of MH include tachycardia, hypercarbia, metabolic and respiratory acidosis, myoglobinuria, and elevated creatinine kinase levels. MH is a life-threatening complication. While most cases of MH occur during general anesthesia, the 1-hour period right after surgery, e.g. in the PACU, is a critical time. Nursing management, temperature changes. Nursing assessment. Take the patient's temperature on arrival to the PACU, and every hour if the patient stays normothermic. If the patient is hypothermic, take the temperature every 15 minutes until normothermia is reached. Use the same route of measuring temperature during the patient's stay in the PACU. Assess the color and temperature of the skin. Communicate risk factors for hyperthermia, or MH, to all members of the perioperative team. Observe the patient for early signs of inflammation and infection that may precede a fever so that any complications can be treated promptly. Nursing diagnoses. Nursing diagnoses related to altered temperature include hypothermia, hyperthermia. Nursing implementation. Passive warming measures include the use of warmed cotton blankets, socks, and reflective blankets in limiting skin exposure. Active warming measures involve the application of external warming devices, including forced air warmers, heated water mattresses, radiant warmers, heated humidified O2, and warmed IV fluids. When using any external warming device, record body temperature and the patient's comfort level at 15-minute intervals. In addition, take care to prevent skin injuries. Apply O2 therapy via nasal cannula or mask to treat the increased demand for O2 caused by shivering. Shivering can be treated with opioids, e.g. meperidine. Keep the supplies readily available to manage MH. Treatment for MH includes the administration of dantrolene, Dantrium, measures to cool the patient, e.g. ice packs, and correcting acid-base imbalances. Use meticulous asepsis with wound and IV site care. Encourage airway clearance with deep breathing, coughing, and use of incentive spirometer. If fever develops, chest x-rays may be taken and antipyretic drugs given. Depending on the suspected cause of the fever, obtain cultures of the wound, sputum, urine, or blood. If a bacterial infection is the source of the fever, start antibiotics as soon as you obtain cultures. If the fever rises above 103 Fahrenheit, 39.4 Celsius, you may use body cooling measures. Gastrointestinal problems. Etiology. Post-operative nausea and vomiting, PONV, are the most common complications affecting as many as 80% of high-risk patients. Risk factors include younger age, under 50 years of age, gender, female, history of motion sickness or previous PONV, non-smoking status, action of anesthetics or opioids, and duration and type of surgery. Delayed gastric emptying and slowed peristalsis that result from handling of the bowel during abdominal surgery contribute to PONV, as does starting oral intake too soon after surgery. Constipation may occur after surgery. It can be due to anesthetics used during surgery that may paralyze the intestine, immobility, changes in diet and fluid intake, and the use of opioids for pain relief. Opioids contribute to constipation by decreasing peristalsis and slowing fecal transport through the intestinal tract. They may also decrease a patient's urge to defecate. Postoperative ileus, POI, is the temporary impairment of gastric and bowel motility after surgery. It results from the handling or reconstruction of the intestine during surgery and limited dietary intake before and after surgery. POI is normal after abdominal surgery and may occur after non-abdominal surgery. After abdominal surgery, motility in the large intestine may be reduced from 2 to 7 days. Motility in the small intestine resumes within several hours after surgery. Risk factors for POI include the use of opioids, immobility, older age, prior abdominal surgery, and early postoperative feeding. Use of opioid analgesia may prolong the duration of POI. Abdominal cramps, increasing abdominal distension, constipation, nausea, vomiting, and dehydration often accompany POI. Hiccups, singultus, are intermittent spasms of the diaphragm caused by irritation of the phrenic nerve, which innervates the diaphragm. The phrenic nerve may be irritated after surgery by gastric distension, intestinal obstruction, intra-abdominal bleeding, or a subphrenic abscess. Indirect irritation of the phrenic nerve may occur with acid-base and electrolyte imbalances. Reflex irritation may come from drinking cold or hot liquids or from the presence of a nasogastric NG tube. Hiccups usually last a short time and stop spontaneously. Nursing management, gastrointestinal problems. Nursing assessment. Ask the patient about feelings of nausea. If nausea is present, assess the severity using a verbal descriptor or numeric scale. If vomiting occurs, determine the quantity, characteristics, and color of the vomitus. Assess the abdomen for distension and presence of bowel sounds. Because bowel sounds are often absent or diminished right after surgery, auscultate all 4 quadrants to determine the presence, frequency, and characteristics of the sounds. The return of normal bowel motility is usually accompanied by passing gas or stool and the ability to tolerate oral intake without nausea or vomiting. Nursing diagnosis. Nursing diagnoses and collaborative problems related to GI problems include nausea and vomiting, electrolyte imbalance, fluid imbalance, potential complications, POI, hiccups. Nursing implementation. When the patient is NPO, give IV fluids to maintain fluid and electrolyte balance. Begin oral fluids as ordered and tolerated. Depending on the type of surgery, the patient may begin oral intake as soon as the gag reflex returns. When starting oral intake, offer clear liquids first and continue the IV fluids, usually at a reduced rate. If the patient tolerates oral intake, the IV fluids are stopped. Be alert to prevent aspiration if the patient vomits while still sleepy from anesthesia. Position the patient in the lateral recovery position and have suction equipment available. Interventions for PONV include monitoring fluid status and giving antiemetic drugs. Consider prophylactic antiemetic drugs for patients at high risk for PONV. Complementary and alternative therapy interventions for PONV, e.g. imagery, music, aromatherapy, acupressure, may help. Constipation may be prevented using bowel protocols that include the use of a stool softener and laxative. Assess the patient regularly to detect the return of peristalsis. Encourage the patient to expel gas. Gas pains tend to become pronounced on the 2nd or 3rd postoperative day. Ambulation and frequent repositioning may provide relief. Positioning the patient on the right side permits gas to rise along the transverse colon and aids its relief. Bisacodyl Dulcolax suppositories may be given to stimulate colonic peristalsis, expulsion of gas, and stool. Resuming a normal diet after bowel sounds have returned also aids the return of normal peristalsis. The goal of treatment for POI is the relief of associated symptoms and return of normal GI function. Management includes bowel rest or the withholding of solid foods with a gradual reintroduction of foods starting with clear liquids. Advance the diet to solid food with an ongoing assessment of tolerance to oral intake. An NG tube may be needed to decompress the stomach to prevent nausea, vomiting, and abdominal distension. Oral care is critical for comfort and stimulation of salivary glands when the patient is NPO or has an NG tube. Urinary problems. Etiology. Low urine output, 800 to 1500 ml, in the first 24 hours after surgery may be expected regardless of fluid intake. Causes include increased aldosterone and ADH secretion resulting from the stress of surgery, fluid restriction before surgery, and fluid loss through surgery, drainage, and diaphoresis. By the second or third day, after fluid has been mobilized and the immediate stress reaction subsides, the patient will begin to have increasing urine output. Acute urinary retention can occur for a variety of reasons. Anesthesia depresses the nervous system, including the micturition reflex arc and the higher centers that influence it. This allows the bladder to fill more completely than normal before the patient feels the urge to void. Anesthesia also impedes voluntary micturition. Anticholinergic and opioid drugs interfere with the ability to start voiding or to empty the bladder completely. Urinary retention is more likely to occur after lower abdominal or pelvic surgery because spasms or guarding of the abdominal and pelvic muscles interferes with their normal function in micturition. Pain may alter perception and interfere with the patient's awareness of bladder filling. Immobility and bed rest impair voiding ability. The supine position reduces the ability to relax the perineal muscles and external sphincter. Oliguria, diminished output of urine, can be a sign of renal failure and is a less common, although more serious, problem after surgery. It may result from renal ischemia caused by inadequate renal perfusion. Nursing management, urinary problems, nursing assessment. Examine the urine for both quantity and quality. Note the color, amount, and odor of the urine. Assess indwelling catheters for patency. Urine output should be at least 0.5 milliliters per kilogram per hour. To decrease the risk of catheter-associated urinary tract infection, CAUTI, remove the catheter as soon as possible or within 24 hours, unless there is a reason to continue its use. Most patients void within 6 to 8 hours after surgery. If no voiding occurs, scan or percuss the suprapubic area for signs of bladder fullness or distension. Nursing diagnoses. Nursing diagnoses and collaborative problems related to urinary problems include urinary retention, potential complication, CAUTI, acute kidney injury. Nursing implementation. Reassure the patient about the ability to void. You can promote voiding by helping the patient into a normal position. Other helpful techniques include providing privacy, running water, offering water for the patient to drink, or pouring warm water over the perineum. Walking, preferably to the bathroom, and the use of a bedside commode are other measures to help with voiding. The HCP often leaves an order to catheterize a patient in 6 to 8 hours if voiding has not occurred. Because of the risk for CAUTI, first confirm that the bladder is full. Consider fluid intake during and after surgery and determine bladder fullness, e.g. discomfort with bladder palpation. Scan the bladder with a portable ultrasound to assess volume of urine in the bladder and avoid unnecessary catheterization. If catheterization is needed, a straight cath, as compared to an indwelling catheter, is preferred to limit the risk of CAUTI. Integumentary problems. Etiology. Surgery generally involves an incision through the skin and underlying tissues, disrupting the protective skin barrier. Wound healing is a major concern after surgery. One of the greatest risks during the perioperative period is SSI. SSIs account for 14 to 16% of hospital-acquired infections and are associated with prolonged hospitalizations, increased costs, and poor patient outcomes. Many are preventable with using evidence-based strategies, e.g. hand hygiene, selection, timing, and duration of prophylactic antibiotics, surgical site skin preparation, maintaining perioperative normothermia. Adhering to these strategies can reduce the incidence of SSIs, a major goal of the SKIP initiative. SSIs may result from wound contamination from three major sources. 1. Exogenous flora present in the environment and on skin. 2. Oral flora. And 3. Intestinal flora. The incidence of SSI is higher in patients who are malnourished, immunosuppressed, or older, or who have had a long hospital stay or a lengthy surgical procedure, more than 3 hours. Patients post-bowel surgery, particularly after a traumatic injury, are at high risk. SSI may involve the entire incision and may extend downward through deeper tissues. An abscess may form locally, or it may spread throughout the entire body cavities, as in peritonitis. Evidence of SSI usually does not become clear before the 3rd to 5th postoperative day. Local manifestations include redness, swelling, and increased pain and tenderness at the site. Systemic manifestations are fever and leukocytosis. An accumulation of fluid in a wound may create pressure, impair circulation and wound healing, and predispose the patient to infection. To allow for drainage, the HCP may place a drain in the incision or make a stab wound next to the incision. Drains may be of soft rubber and drain into a dressing, or firm catheters attached to a hemovac or other source of gentle suction. Adequate nutrition is essential for wound healing. The patient who is well nourished before surgery can tolerate the lack of nutritional intake for several days. However, the patient with pre-existing nutritional deficits that occur with chronic diseases, e.g. diabetes, ulcerative colitis, alcoholism, is more prone to problems of wound healing. A patient who cannot meet nutritional needs may need enteral or parenteral nutrition to promote healing. Nursing management, surgical wounds. Nursing assessment. Assessment of the wound and dressing requires knowledge of the type of wound, the drains inserted, and expected drainage related to the specific type of surgery. Immediately after surgery, check the wound every 15 to 30 minutes or as ordered. When drainage appears on the dressing, record the type, amount, color, and odor of drainage. Assess the effect of position changes on drainage. A small amount of serous drainage is common from any type of wound. If a drain is in place, assess the amount of drainage and compare to what is expected. Expected drainage from tubes is outlined in Table 19.7. An abdominal incision with an accompanying drain will likely have a moderate amount of serosanguinous drainage in the first 24 hours. In contrast, an inguinal hernia or raphe should have only minimal serous drainage. In general, expect the drainage to change from sanguinous red to serosanguinous pink to serous clear yellow. Purulent drainage may occur with an SSI. The drainage should decrease over hours or days, depending on the type of surgery. Wound dehiscence, separation and disruption of previously joined wound edges, may be preceded by a sudden discharge of brown, pink, or clear drainage. Wound dehiscence is discussed in Chapter 11. Notify the HCP of any excess or abnormal drainage or significant changes in vital signs. Nursing diagnosis. Nursing diagnosis related to surgical wounds include surgical wound, risk for infection. Nursing implementation. The incision may be covered with a dressing right after surgery. Many HCPs prefer to change the first postoperative dressing if the initial operative dressing is saturated. Follow agency policy as to whether you should change or simply reinforce the dressing. Skin graft dressings may stay in place for 3 to 5 days to avoid disturbing the graft site and promote graft acceptance. Specially trained nurses may change these dressings. Skin grafts are discussed in Chapter 23. When you change dressing, note the number and type of drains present and avoid dislodging the drains. Inspect the incision site carefully. The area around the sutures may be slightly reddened and swollen, which is an expected inflammatory response. However, the skin around the incision should be of normal color and temperature. If the wound is healing by primary intention, has little or no drainage, or has no drains in place, a single layer dressing or no dressing is sufficient. Use a multi-layer dressing when drains are in place, moderate to heavy drainage is occurring, or healing occurs other than by primary intention. Discharge from the PACU. The choice of discharge site is based on patient acuity, access to follow-up care, and the potential for complications. The decision to discharge the patient from the PACU is based on written discharge criteria approved by the agency's anesthesiology and medical staff. Standardized scoring systems, e.g. modified Aldrete scoring system, are often used to determine the patient's general condition and readiness for discharge from the PACU. Discharge to clinical unit. Before discharging the patient from the PACU to the clinical unit, give a handoff report about the patient to the receiving nurse. The report summarizes the operative and post-anesthesia period. It should include information as to where the patient's caregivers are waiting. Nurse-to-nurse communication must be accurate and allow for questions. The use of a standardized communication tool, such as SBAR, Situation Background Assessment Recommendation, provides a complete report and enhances a safe transfer of the patient from PACU to the clinical unit. When you receive the patient on the clinical unit, assist the PACU transport staff to safely move the patient from the stretcher to the bed. Take care to protect IV lines, drains, and traction devices. Obtain vital signs and compare the patient's status with the report provided by the PACU nurse. After this, perform a more focused assessment and initiate postoperative orders and nursing care. Ambulatory surgery, phase 2, and extended observation. Advances in minimally invasive and non-invasive procedures, anesthesia, and analgesia have resulted in an increase in ambulatory surgical procedures. Ambulatory surgery patients include those patients receiving phase 2 and extended observation postoperative care. PONV and pain are common problems after ambulatory surgery. These can lead to delirium, prolonged PACU stay, delayed discharge, readmission, delayed resumption of usual activities, and decreased patient satisfaction. Ambulatory surgery discharge. Patient leaving an ambulatory surgery setting must be hemodynamically stable, mobile, alert, and able to provide a degree of self-care when discharged to home. PONV and pain must be under control. Overall, the patient must be stable and near the level of preoperative functioning for discharge from the unit. The patient may not drive and must be accompanied by an adult at the time of discharge. Carefully assess the patient's readiness for discharge and home care needs. Determine availability of caregivers, e.g. family, friends, and access to 1. A pharmacy for prescriptions, 2. A phone in the case of an emergency, and 3. Follow-up care. Planning for discharge and follow-up care. Preparation for the patient's discharge is an ongoing process that begins before surgery. Include the patient and caregiver in discharge planning and provide them with the information and support to make informed decisions about ongoing care. The informed patient is prepared as events unfold and gradually assumes more responsibility for self-care during the post-operative period. As discharge approaches, be sure that the patient and caregiver have the following information. Symptoms to report, e.g. fever, increased incisional drainage, unrelieved incisional pain, discomfort in other parts of the body, when and how to take prescribed drugs and possible side effects, care of incision and any dressings, including bathing recommendations, activity allowed and prohibited when various activities can be resumed safely, e.g. driving, return to work, sexual intercourse, leisure activities, dietary restrictions or modifications, where and when to return for follow-up appointment, answers to any questions or concerns. Common reasons patients seek help after discharge include unrelieved pain, need for advice about drugs, and wound issues, e.g., drainage. Attention to complete discharge instructions may prevent needless distress for the patient and caregiver. Standardized pre-printed discharge instructions that are surgery specific and easy to read ensure that information is complete. Record the discharge teaching in the chart. For the patient, the postoperative phase of care continues and extends into the recuperative period. Assessment and evaluation of the patient after discharge may be done with a follow-up call or by a visit from a home health nurse who can address any specific questions and concerns. Increasingly, patients are discharged from the hospital with many care needs. They may be transferred to transitional care facilities, to long-term care facilities, or directly to their homes. When discharged directly to home, the patient is expected to continue self-care with help from caregivers or home health care personnel, e.g., nurses, physical therapists. Care may include dressing changes, wound care, catheter or drain care, home antibiotics, or continued physical therapy. Working together with the discharge planner or case manager, ensure the patient's safe transition from hospital-based care to community or home-based care. Gerontologic considerations. Postoperative patient. The older surgical patient deserves special consideration. The older adult has decreased respiratory function, including decreased ability to cough and decreased thoracic compliance. These changes lead to an increase in the work of breathing and a decreased ability to eliminate drugs. Carefully monitor reactions to anesthetic drugs. Pneumonia is a common complication in older adults. Altered vascular function in the older adult is due to atherosclerosis and decreased elasticity in the blood vessels. Cardiac function is often compromised with limited compensatory responses to changes in BP and volume. Circulating blood volume decreases. Hypertension is common. Cardiovascular status needs to be monitored closely throughout surgery and the postoperative period. Drug toxicity is a potential problem in the older adult. Renal perfusion normally decreases, along with a reduced ability to remove drugs that the kidneys excrete. Decreased liver function leads to reduced drug metabolism and increased drug activity. Carefully assess renal and liver function to prevent drug overdose and toxicity. Observing for changes in mental status is an important part of postoperative care in older adults. Factors such as age, history of alcohol abuse, poor baseline cognition, hypoxia, metabolic imbalances, hypotension, and polypharmacy can contribute to postoperative delirium. Anesthetics, especially anticholinergic and benzodiazepine drugs, increase the risk for delirium. Pain control in the older patient is challenging because of possible pre-existing cognitive deficits, impaired communication, and physiologic changes that affect drug metabolism. Patients may hesitate to ask for pain medication because they believe pain is inevitable with surgery. Some older patients may fear addiction or be nervous about using PCA machines. Thoroughly assess pain in a surgical patient who does not report any pain. Encourage the use of analgesics. Explain to the patient and caregiver that untreated pain has a negative effect on recovery.